Good afternoon to you, ladies and gentlemen. I'm O.P. Yadav, Editor-in-Chief of Indian Journal of Thoracic and Cardiovascular Surgery and CEO, National Heart Institute in Delhi. It's our proud privilege to have Professor D. Bartolomeo Roberto from University of Bologna. Welcome, Professor.
Thank you.
Professor, you have been on the forefront of aortic surgery and probably one of the largest series of frozen elephant trunks. So our congratulations. And that's where I want to pick your brains on, essentially on redo aortic surgery. First thing I would like to know is, why do you actually need redo operations in aorta, and what is their current incidence?
In the last year, the number of the patients that arrive in our institution for the redo operation in thoracic aorta increases. The reason is many. First, the increasing age of the patient, especially in Europe,
Sure.
in USA, in Canada, and the increased number of the operation. The increased number, the implantation of the biological valve. In USA, in the last year, 80% of the patients that underwent to valve replacement made the implantation with biological valve. The increasing number of the infection, endocarditis in the prosthesis and the native valve. The increased number of the patients that perform the acute type A aortic dissection or type B acute dissection come back because the increasing diameter of the false lumen.
Okay.
And this patient have the indication to the operation. This is the majority of the reason, because the number of the reoperation increase in our center.
So what is the percentage of people who, after a type A aortic dissection, still have a patent false lumen and a dilating false lumen?
The false lumen in 100% of the patient remain open.
Okay.
And the enlargement of this false lumen depends on many factors. Hypertension first. The second, the presence of more reentry tear. And this patient develop the enlargement of aorta, especially in the first part of the descending aorta. Another problem is that the majority of the patients that underwent in acute type A aortic dissection perform the substitution only the ascending aorta and hemiarch. This is the most common operation. And this patient have the disease of the aorta and come back for three reasons. One, because the patient have the enlargement of the sinus of Valsalva, the aneurysm. Second, the aortic valve insufficiency. And third, the enlargement of the false lumen in the arch in the descending aorta. This is the reason, three reasons for the reason that the patient come back to perform the redo operation.
So if you have to answer these reasons, can I ask you that in the primary first operation of type A aortic dissection, how do you decide just to proceed with a tear-oriented operation, that is hemiarch and only ascended aorta, or to go for more extended an elephant trunk, which is a staged procedure, or a single-stage frozen elephant?
Good questions.
Yeah.
For us in Bologna, but in the majority of the center where this pathology, this technique, the aortic, thoracic aortic surgery, the indication now is to perform the frozen elephant trunk in the patient that have the primary lesion in aortic arch,
Okay.
young patients, in patient that in patient with acute type B dissection, with a retrograde dissection in ascending aorta or in arch, or where there is the impending rupture in the first part of the descending aorta and is not amenable to put the endoprosthesis because, for example, the diameter of the arch is too big, or if there is a big angulation between the aorta and the descending aorta. In this case, the indication for frozen elephant trunk for complete substitution of ascending aorta, valve, and the arch and the frozen trunk, there is the indication. Another, if the experience of the surgeon, naturally, all this depends on the experience of the surgeon. Another good point is the preserve or no the valve, the aortic valve. Today is possible if the surgeon have a good experience in aortic valve in aortic valve, not substitution, but the repair, the aortic valve, to have big experience in David procedure. Here there is the indication to, if there is naturally the anatomy favorable, to perform the David procedure also in this patient. Naturally, it's a long operation. Probably the patient have more probability to have a problem, but in good hands, in good surgeons that have experience in this field, the result now is very, very promising.
So what are the results, the long-term results of, say, a frozen elephant trunk in a young type A aortic dissection?
I don't know. Now it's impossible to know this because this technique started only some years ago. It's possible in the center that my center they have a good big experience in this technique. In some cases, we had a complete thrombosis of the false lumen.
Did you have any case of a redo surgery in a frozen elephant trunk where you had to?
But not in the arch
Not
or in the last part, because the patient arrived with the dissection of all the aorta, and we all these patients come one time every year in our institution to perform the CT scan to study if the false lumen increase or no.
Okay.
And we have many techniques. Generally, if the diameter of the descending aorta increase, we use the endovascular prosthesis using with the proximal landing zone the frozen elephant trunk, and arrive with the prosthesis until the celiac trunk. If the patient then have the enlargement of the abdominal aorta, we have two possibilities. One, if the young patient is in good condition, we perform the open surgery, the thoracoabdominal repair, starting from the endoprosthesis until the bifurcation of the aorta. But if he's an old patient, the patient with BPCO, if the patient has some problem, we perform the hybrid repair of the abdominal aorta. I performed the laparotomy, and I made the substitution of the abdominal aorta using the Coselli prosthesis. You know, Coselli prosthesis have 3 branches in the right part, 1 branch in the left part. I use this 4 branch to reimplant all the visceral vessels. And I create the 2 centimeter of landing zone, and then in the second time we perform the endovascular prosthesis from the prosthesis in descending aorta until our aorta in abdominal part.
Okay.
With this technique, in 22 consecutive cases, we don't have paraplegia, don't have
no spinal cord issues.
no spinal cord, no renal insufficiency.
Okay.
It's very important also.
And what is your follow-up protocol for these patients with frozen elephant trunk? How often do you follow them up, and with what imaging modality?
CT scan.
CT scan. And what in intervals?
Every 1 year.
Every 1 year.
Every 1 year.
So, ladies and gentlemen, you just heard Professor Bartolomeo, and he feels that a lot of these redo surgeries are in type aortic dissection because we are not handling the residual problem in the first go in the arch, and that is very important that we start tackling them more aggressively the first time round, especially if the patient is young. And frozen elephant trunk is a technique which he feels can be learned with reasonable degree of comfort if only you have experience in basic aortic surgery. Well, Professor Bartolomeo, thanks a lot for sharing your time with us, and appreciate your coming to us.
Thank you very
Thanks
much
a lot.
for the invitation.
Thank you.
Thank you.